Brenda Santillán, and Dr. Patton and I will be serving as co-facilitator during this session. I would like to ask to all of you to use your gallery view and to welcome to all of our primary care providers, to our teledermatology team, our dermatologists, Dr. Rabinovich, Dr. Buchanan, and Dr. Davis, I don't know if she's here. Also to our family medicine residents, dermatology residents, or medical students. Here in the hub, we have to Kenza Mamuni and Marisol Miranda. Please, Dr. Patton, go ahead.
Well, thank you very much, Dr. Santillán. Again, my name is Doug Patton. I am MCG's Associate Dean for the Southwest Regional Campus. It's good to be here. This is our 12th session. And as usual, we're going to start off with just a few just reminders. And as you can see from, we just reviewed the agenda, but then we got the title slide for Project ECHO, which is moving knowledge instead of people. ECHO standing, of course, for Extension for Community Healthcare Outcomes. Next slide, please. Again, our goal here is to improve knowledge and your ability to provide care for your patients where you are and where they are by increasing your confidence and your abilities with dermatological diagnosis, and particularly in use of the Dermatoscope tool that we have. This, we hope, will address some of the dermatologic health disparities that we see, along with the other health disparities around the state. Next slide, please. So again, the sessions are recorded. You've seen the prompt for that on your screen. And by participating and continuing to participate, you are consenting to being part of that recording. As a reminder, these are not consultative and secure conversations, so please do not mention PHI in the discussions. There will be information towards the end of the presentation, towards the end of the hour, and also in the chat on how to claim your CME and nursing education credits as well. Of course, you can always email teledermatology@augusta.edu with questions. And while we're live, putting them in the chat is probably the best way to do that. We thank everyone for putting your name, email address, and who you're affiliated with in the chat now. Let's see, next slide, please. So we do collect data while we're here. It's part of what we do so that we can improve. That includes registration data. If we do polls and question and answer where we record the answers, that might help us to inform future programs and help meet your needs. We also share this data with Project ECHO folks, which contributes to the worldwide base of information that Project ECHO is developing to improve education and healthcare outcomes around the world. Next slide, please. So again, CME and CNE information will be on the final slide and also in the chat. You can email Kenza Mamuni@augusta.edu if you have any technical issues during this. And again, the teleDermatology@augusta.edu email address is always there if you need it. But during the live sessions, the chat's probably the most effective way to do that. All right, let's see. I think that's the last slide for me. Yep. All right. So it's my privilege again to introduce Dr. Kendall Buchanan. She is once again our featured speaker. Today, she's going to talk to us about vascular patterns. Dr. Buchanan, we thank you again for your commitment to educating us all through this process. And at this time, if you're ready, you can share your screen and we can begin.
All righty. So today, as Dr. Patton said, we're going to be talking about vascular patterns. I'm also going to open up the chat for you guys to think about what lectures you would like to see moving forward. We've primarily focused on dermoscopy, which we will continue to focus on, but if there's other topics that you're interested in, like sun protection, full body skin checks, autoimmune skin conditions, eczema, psoriasis, just please let us know in the chat, and we're going to try to target some of these lectures as well moving forward. Oops, sorry. Okay, so I just want to mention Dermoscopedia. I've mentioned this site before. It's a wonderful resource for you guys. And I do use some of their beautiful schematics from their website. So with vascular patterns, they're very important in dermoscopy, and we've talked about vascular patterns in relation to specific neoplasms like basal cell, squamous cell, but tonight we're just going to focus on vascular patterns. And you can see here, we use these, or the identification of these polymorphous vessels. This is an example of a recurrent melanoma. And so you can use these vascular patterns to help identify both melanocytic and non-melanocytic skin lesions. And as you know, pink, brown, and red structures and neoplasms can sometimes be very challenging. So the identification of vascular patterns can help make this a little bit easier for us. This was an example of polymorphous vessels that I saw with this moderately differentiated squamous cell carcinoma. And so it's important to kind of understand how to use your mole scope or your dermatoscope when you're looking at neoplasms. And so in order to best see the vascular structures, you want to use very light pressure and have your dermatoscope in the polarized mode, typically non-contact. And so another step to do that, you also want to make sure you either have alcohol or gel, because it really causes those vascular structures to be in better view. So, and when everyone's skin is super dry this time of year, you really do have to use some form of alcohol, whether you use an alcohol wipe to kind of minimize the scale, a little drop of alcohol or some gel will help you. So with the mole scope, there's only one mode, and that's polarized light only. So you're already kind of using that feature. So you don't really have to think about toggling back and forth. When you use your dermatoscope, what you have to do is use this button here, and you have to press it back and forth, and that toggles back and forth between polarized and non-polarized light. Usually it's pretty easy to tell because those vascular structures are really highlighted when you use that non-contact polarized mode. And this is an example here of a digital mucus cyst where you can see I had minimal pressure with alcohol or gel on the left. And then on the right is an example of where the dermatoscope was held too firmly on the skin lesion and the blood vessels blanched out. So as I mentioned, these structures are best visualized in the non-contact polarized mode, as you can see on the far right. And so we're going to talk about vascular patterns in terms of the arrangement and the morphology of the blood vessels. So we'll start with uniform. So these are vessels that are arranged in a uniform pattern, so it's consistent throughout. So this is an example here where you see multiple vessels as dots that are distributed evenly across this lesion. Another example here, this is an intradermal nevus where you see these slightly curved vessels that have a uniform distribution throughout this lesion. Non-uniform, so these vessels are arranged in a pattern that's inconsistent. And so in this case, you can see here, you have some vessels as dots and linear irregular vessels. They're distributed unevenly throughout. And then another example here of a non-uniform pattern, you have multiple different, you have some arborizing vessels, some linear irregular vessels, and some small circular vessels that are unevenly distributed. And this is a superficial and nodular basal cell. Vessels can also be assembled in clusters or groups. This is an example here where you see these small coiled vessels that are grouped together. Another similar example where you see small coiled vessels that are in these tight groups. And these are both examples of the squamous cell skin cancer. You can have vessels in a radial pattern. And so typically these are linear vessels that sort of radiate around the periphery. You can also sometimes see more circular vessels as well. This is an example here. You see this pink papule. This is my son's back. And here, this was a molluscum contagiosum, where if I use minimal contact in the polarized mode, you can see these vessels that radiate around. And then if I put too much contact, you can see it completely blanches out the vascular pattern. Another example here where you see this keratotic papule, and then you see these small coiled vessels that are distributed around the periphery. This is a type of squamous cell carcinoma called a keratoacanthoma. Vessels can also be arranged as dots, and they can form this reticular or string-like pattern. This is an example here of a string-like pattern that we see with a benign lesion called a clear cell acanthoma. Another example here where you see these small vessels that form lines, and they're typically in this string of pearls formation. Another example here where you see these small vessels as dots that are appearing in lines throughout. And this is another example of a clear cell acanthoma. The strawberry pattern, we've talked about this before, specifically when we've talked about actinic keratoses. This is mainly a reddish pseudo network that typically forms around the hair follicle. And then you can also see these follicular openings that are accentuated with a white halo. This is an example here of a patient of mine who had this scaly plaque on her left upper cutaneous lip. You can see these fine wavy vessels, yellow follicular openings, and this red pseudo network. And this is called the strawberry pattern. Another example here, red pseudo network, where you see yellow follicular openings, and you can see those fine wavy telangiectasias. And so this is another example of the strawberry pattern. I've also seen this occasionally in other areas, such as the dorsal hand, or in other areas where the skin is very thin. So this is an example here. You can see scale, you can see these white circles and this red pseudo network. And this was biopsied and diagnosed as a squamous cell carcinoma in situ. Now, we've talked about the arrangement of vessels. So now we're going to dive into the morphology of vessels. And we're going to start with vessels as red dots. So these are very small, 0.01 to 0.02 millimeters in size. The differential for vessels as red dots is fairly broad and consists of non-melanocytic and melanocytic skin lesions. So we'll start with squamous cell carcinoma. So this example here, you can see these vessels as dots. Sometimes it can be challenging to know if they're vessels as dots or they're vessels as tight coils. That's okay. We see vessels as dots. We also see scale, and we also see rosettes. So this is a pattern that we've talked about before in relation to squamous cell carcinoma. Another example here, you see diffuse vessels as dots, some vessels as coils with some central scale crust. Another example of a squamous cell carcinoma in situ. This was a very broad, scaly, thin plaque on this patient's forehead. You can see numerous vessels as dots with scale, and this was also a squamous cell carcinoma in situ. Now, we briefly spoke on porokeratosis before, so you guys are very familiar with these. We talk about these in this case because sometimes you can see vessels as dots that are diffusely distributed throughout the lesion, as well as the keratin rim that we've talked about before that's fairly specific to porokeratosis. Another example here, diffuse vessels as dots with that thickened peripheral keratin rim. You can also see this pattern with psoriasis. This isn't the best photo, but this was an isolated pink scaly plaque on this patient's lower leg. I knew she had a history of psoriasis. So what you see are these diffuse vessels as dots with a clinical and dermatoscopic scale. A clear cell acanthoma, we just went over this. As I mentioned, these vessels as dots are often in this string of pearl formation. So you can see here's how they form in lines that are slightly curved in that string of pearls fashion. Dermatofibroma, we've talked about these patterns before. We often mention this peripheral reticular network with this central scar-like area. This is an example of that same pattern, but in the center, you see these vessels as small dots, but you still have your peripheral network and central scar-like area. Another example here, that peripheral pigment network, central pink-white scar area. And then you also see these tiny vessels as dots located slightly off center. Lichen simplex chronicus. So this is what happens whenever you have an itchy area and you continue to rub it, scratch, or occasionally pick at it over and over. It creates what we call lichen simplex chronicus. And so this is an example here where you can see these vessels as dots arranged in lines in that peripheral pattern. You can also see numerous shiny white structures that form this linear radiating pattern, central erosion, and also some blood spots. So this is an example of lichen simplex chronicus. So not a skin cancer, but something that happens when an area is rubbed or scratched over and over. Lichen planus-like keratosis, we've talked about these before, mostly in relation to pigmented lichen planus-like keratosis, but this is an example here where you can see a pink neoplasm that has diffuse vessels as red dots, and when biopsied, this was a lichen planus-like keratosis. Now, as I mentioned, you can also see vessels as red dots in melanocytic lesions, especially melanoma and Spitz nevi. So this is an example here where you see diffuse vessels as red dots, along with numerous white shiny structures, and this is a Spitz nevus. Similarly, you can see these diffuse vessels as dots and this irregular dark pigment with atypical globules. This is a spitzoid melanoma. So now we'll move on to clods. So these are oval structures. They're also called lacuna, and they are very characteristic of vascular lesions. And so you guys probably see these all the time. Most anyone over the age of 30 has what we call cherry angiomas. These are benign, very common. These consist of multiple round oval red structures and usually these white septae. Another example here where you see multiple round oval red structures. Now, not to scare anyone, but you can also see these red clods in melanomas. And so this is an example here of an invasive melanoma where you see these pink and red oval structures or lacunae, and this was a melanoma. Another example here, these are referred to milky red globules, and they can be seen typically in more advanced invasive melanoma. This is an example here. I saw this patient about a month ago, so you can see how clinically this is very atypical, very disorganized, extremely concerning for melanoma. You see your blue-white veil, you see your atypical pigment network, multiple shiny white structures, and then here you see this milky red area. So this is a very advanced stage T4B melanoma. A closer up here of these milky red areas. Next, we'll talk about coiled or glomerular vessels. And so we get this because they resemble the renal glomerular capillaries. So they're very tightly coiled. And as I mentioned, sometimes they can be challenging to differentiate between vessels as dots, but we usually see both of these patterns in association with squamous cell carcinoma. So here you can see these vessels tightly coiled and dotted vessels, and this was a well-differentiated squamous cell carcinoma. Here again, vessels that are tightly coiled, some are looped, and this was a squamous cell carcinoma in situ that was arising in a seborrheic keratosis. So we're very familiar with a specific type of vessel called serpentine branched, or what we also call arborizing. And so these are fairly specific for basal cell carcinoma, but keep in mind you can see these in other skin neoplasms, adnexal tumors, digital mucus cysts. I showed you an example of that at the beginning. fibrous papules, intradermal nevi, cysts, hypertrophic scars, and keloids. So you can see here, these serpentine branch vessels or arborizing vessels are very sharply in focus, and they're bright red. They can have large or small diameter, and typically you'll see a larger caliber vessel that divides into these smaller vessels. So, and this is highly sensitive and specific for basal cell carcinoma. So you can see in this example, these serpentine branch vessels to the left of this neoplasm. And then on the right is that our features of a seborrheic keratosis, those ridges and fissures that we've talked about. So this is a collision lesion between a basal cell carcinoma and a seborrheic keratosis. Here is another example of a basal cell carcinoma. You see these small diameter branching vessels. And so you can also have serpentine vessels that are in more of a radial pattern, and we typically see this pattern when we talk about sebaceous hyperplasia and molluscum contagiosum, and they have a positive predictive value of about 83.3%. So in contrast to the bright red vessels that we see with basal cell carcinoma, these tend to stay at the periphery and don't cross over the midline. You also typically see these yellow to white popcorn-like structures as well. So here in this example, you can see those popcorn-like globules, those serpentine radial vessels that do not cross the midline. These also tend to be more dull in color as compared to the bright red color of the arborizing vessels seen in basal cell carcinoma. This is actually an example of a nevus sebaceous, but again, you can see those serpentine radial vessels that are mostly at the periphery and don't cross into the midline. Another example here, in the center here, you see these yellow to orange brown oval structures, and then at the periphery, these serpentine radial vessels, and this is an example of a molluscum contagiosum. Looped, half-looped, or twisted vessels. So we'll talk about these. So half-loop, the vessel has a U shape. So it looks like a hairpin. So we often use the term half-looped or hairpin interchangeably. Twisted loop vessels just means the vessel has lots of twists and turns, and it twists on its own axis. And so the reason these vessels are important to recognize is that they can be seen in non-melanocytic and melanocytic skin lesions, non-melanocytic, typically with keratinizing tumors. So I see these usually with squamous cell carcinoma and inflamed keratoses. And so an example here of a squamous cell carcinoma where you see at the periphery here, you have these half-looped or hairpin vessels. And then here you can see another example of these hairpin-like or looped vessels in a keratoacanthoma. And then this is an example of an inflamed seborrheic keratosis. So it can be very challenging to differentiate these from squamous cell carcinoma, but you can appreciate the vascular pattern is consistent with those hairpin or looped vessels, and they can be seen in inflamed seborrheic keratosis. This is an example here. We've talked about features of basal cell carcinoma before. This is a pigmented basal cell carcinoma where you can see these leaf-like areas along with those blue ovoid nests. And here up top, you see these twisted loop vessels that can be seen in basal cell carcinoma. They're less common than arborizing vessels. And when we do see them in basal cell, we do tend to think about them being possibly a recurrent basal cell carcinoma. You can also see vessels as lines slightly curved. These tend to be distributed evenly, and you can see these in intradermal nevi. Another example here. Comma or curved vessels. So these just have a slight bend, so not as sharp of a U-turn like we talked about with those hairpin vessels. And these are also highly suggestive of dermal and congenital nevi. You see here numerous vessels that are curved or comma shaped in this benign nevus. And so you can see these vascular patterns where you have linear, curved, and serpentine vessels. You often see these together. And these are typically seen with congenital and intradermal nevi. And so this is an example here where you see these slightly linear vessels, and then you see these slightly curved vessels in this intradermal nevus. Another example here, you have your curved vessels and you have your linear serpentine vessels in an intradermal nevus. Linear random or linear irregular vessels are very important to be able to identify. They typically have, like I said, a random or haphazard distribution, and they can be highly suggestive of melanoma. So here, a little challenging to see, but you can see these linear vessels that are distributed irregularly throughout this neoplasm, and this is a melanoma. So when we talk about melanoma, we don't always see vascular patterns, but we do know that the most common vascular patterns seen with melanoma typically consist of polymorphous vessels. And that just means the combination of two or more vessel types. The most common pattern that we see are the vessels as dots, which we talked about earlier, and also these linear irregular vessels. So here you can see at the periphery, these vessels as dots, and then these numerous linear irregular vessels, along with areas of brown, which represent that atypical pigment network. And so this is an example of polymorphous vessels that we see with melanoma. Another example here, this was a recent case. You can see, it's very atypical overall. You have multiple atypical dots and globules, a relatively brown to black structureless area, but then you also see these linear irregular vessels and these vessels as small dots. So this was an invasive melanoma stage T2B. Finally, you can see these serpentine and slightly curved vessels and dotted vessels. So not all neoplasms that have different types of vascular patterns are going to be suggestive of melanoma. In this case, you can also see this golden brown halo, and these are all typical of an intradermal nevus pattern. So in summary, the vascular structures can be very important to help you diagnose a skin neoplasm as benign or malignant. So just keep in mind how to use that dermatoscope, apply minimal pressure, make sure you use alcohol or gel, and then that can help you come up with a great differential that can guide you to do a biopsy or send a referral. So think about the pattern, the distribution, the morphology, and look for if it's a monomorphous or a polymorphous pattern. And so I thank you guys for letting me speak to you so much. I know everyone is not getting tired of me speaking, but we do want to kind of open the door and allow other speakers to help out with some of these presentations. And so, as I mentioned, you can write in the chat, just let us know what topics you're interested in. And then our team will work together to try to find different speakers, as well as continue to bring you dermoscopy education. Thank you.
Thank you, Dr. Buchanan. That was great, as usual. I appreciate particularly your invitation to others to not only submit, ideas for future topics, but also to join in and help participate. I put in the chat just for everyone's reference, the Dermoscopedia. That's a little bit of a challenge for me to say that. Dermoscopedia website, and also as a reminder, the Derm Engine website for the mole scopes, in case you need some refresher on how to use the devices. I think it's super important for us to realize that the best way for people to get used to understanding the complexities of everything that you've described here today is to use the mole scopes and to get used to looking at them that way, and sharing the images up for consultation. We all know that consultation may serve the purposes of answering a question for a patient, but it's also one of the best ways that we all get education. I was looking in the chat to see if there were any questions. I don't see any there for Dr. Buchanan, other than a request to share the PDF. And I'm guessing, Dr. Salgado, that is for the PDF for the slides. Is that, and I believe that was answered already. Any questions? Anyone want to raise their hand, open their mic before we move on to the next part? I did want to ask Dr. Buchanan, just so that you know, so that we all know, is it fair to say that particularly in darker pigmented skin, that the use of some sort of dermatoscope, polarized or non-polarized, either way, helps us to be able to differentiate some of the things that might be hard to see without the device?
Yes, I mean, I think it is challenging to, I think we're still learning as a group. We're getting better and better at diagnosing neoplasms in skin of color. So, certainly the vascular structures can be less obvious in skin of color, especially if you have a deeply pigmented skin lesion. But I think in totality, the lectures that we've spoken on so far, we've talked about pigmented basal cell carcinoma in skin of color. We've talked about melanoma in skin of color. So I think dermoscopy is helpful in, any patient's skin type. I can't say that I've had a lot of experience picking up vascular patterns in skin of color, but certainly you can see them, but I just haven't personally had that experience.
All right. Well, great. Well, thank you for that. All right. Thanks for the comments. Please respond to Dr. Buchanan's request and invitation to submit topics for future consideration. Again, we would love to have more presentations from the participants. But at this point, it's my pleasure to move us on to the next part of the agenda and get right here. For the second presentation, we have a case to be presented by John Hetzel, who's a fourth-year medical student. John, we appreciate you being with us today. Appreciate your interest in the teledermatology TeleECHO. And if you're ready, you can share your screen and proceed.
All right. Give me 1 second to work on that. All right.
Good. We can see it.
You can see it. Okay, perfect. Well, like you said, my name's John Hetzel. I'm a medical student, Medical College of Georgia. I'm just going to do a brief case presentation, kind of highlighting some of the stuff Dr. Buchanan just talked about. All right. So without further ado, have a clinical vignette of a 70-year-old male patient with a history of non-melanoma skin cancer presenting for a routine skin check with a single spot of concern. So he noticed an asymptomatic pink bump on his frontal scalp present for kind of an indeterminate amount of time. It's a pretty common kind of occurrence. So if I can get to, there we go. So this is the man's head, and then this is the spot in question. So you can see a thin kind of pink to red papule on the left frontal scalp with maybe a little bit of light scale, a few pinpoint hemorrhages, kind of not immediately discernible as to what it is necessarily. And then on dermoscopy, can kind of get a better picture of what's going on. And so I think, very prominently right away, you can see there are, numerous very visible blood vessels, and some of which, like Dr. Buchanan had mentioned, are, of these hairpin or twisted loop morphologies. So looking at A, you can see some, very good examples of, classic, half loop or hairpin loop vessels, some of which have, kind of slightly whitish halos around them. And then in, image B, you can see a larger twisted loop vessel, in this case, not in a hairpin configuration, but also potentially with some peripheral halo. Some additional features that are not vascular, which which are very prominent again on this photo, are some milia-like cysts and comedone-like openings visible in A, as well as potentially some shiny white structures, though there could potentially also be some artifact from blanching. You can see that this area is very white compared to the rest of the lesion. And I think there was a little bit of extra contact there. So something important to remember, like Dr. Buchanan had mentioned, was making sure not to apply too much pressure when looking at vascular lesions. So some of the things that we think of, Dr. Buchanan went over the differential for kind of loops here, but things we think of with twisted or hairpin loop vessel patterns, things that are benign would be, seborrheic keratoses and irritated seborrheic keratoses. And then some things that are malignant would include, keratoacanthoma or squamous cell carcinoma, as well as melanoma and, more rarely basal cell carcinoma. So a punch biopsy was done of the lesion, just diagnostic uncertainty. And on pathology, we can see some epidermal acanthosis, but no keratinocyte atypia. If you look at the base of the lesion, it has like a very abrupt cutoff. This is sometimes known as a string sign. And it kind of gives a little bit more. This is actually a seborrheic keratosis, and it kind of gives a bit more of a, to the name, stuck on lesion. And then the arrow at the top there is pointing at a keratin invagination. Just some closer images, you can see, benign keratinocytes on the left and right image, as well as the middle photo, the large circular structure there is a milia-like cyst. So seborrheic keratoses, I'm sure everyone's very familiar with these for the most part. Common benign keratinizing tumor with a wide spectrum of morphologies. It can look really like anything. Some typical dermoscopic features include, like we had just mentioned, milia-like cysts and comedone-like openings, as well as things like fissures, ridges, these classic hairpin blood vessels, and then sharply demarcated borders. So seborrheic keratoses can be challenging to differentiate from some malignancies like squamous cell carcinoma and melanoma, particularly if they're irritated or deeply pigmented or any number of other things. And so one thing we can kind of think about is what features are, better for kind of pushing us more towards, is this a benign lesion, or is this more likely to be a malignant lesion? And so some dermoscopy features, which are good positive predictors for something that's like an irritated seborrheic keratosis, hairpin loop vessels where, they have that kind of peripheral halo, that single turn. These are very common in seborrheic keratosis in general, as well as irritated seborrheic keratoses. So they're a good positive predictor. A diffuse, more regular vessel arrangement, and then white halos around vessels in greater than 10% of the vessels in the lesion are good positive predictors for something like a seborrheic keratosis. Then, interestingly, hairpin loop vessels are actually also very common in squamous cell carcinoma. They're more common in seborrheic keratoses, but things like, a greater prevalence of dotted vessels, which are a very strong indicator for squamous cell carcinoma, central scale distribution, particularly in the case of something like a keratoacanthoma, or a diffuse, irregular, or peripheral vessel arrangement. Those things are good predictors for squamous cell carcinoma. And short case, so open the floor to any questions. Yeah.
Thank you, John. Thank you very much. That was very interesting, and appreciate the effort you put into sharing this with us this afternoon. I'm looking at the chat. I don't see any. I'm glad to entertain any questions from the crowd. You can raise your hand by going to the reactions button and do that. We can find you then and call you out. Or at this point, if you just feel so bold, you can open up your mic. While we're seeing if there's other questions, I may just ask Dr. Davis and Dr. Rubinovich if they have any comments on John's presentation at this point.
It was very well done, and John covered the essential points. Vascular lesions can be difficult, especially vascular lesions when you're looking for melanoma. The shades of pink melanoma are challenging. And as Dr. Buchanan mentioned, the most common things that we look for are either vessels as dots in association with white shiny structures or polymorphous vessels. And when you look at dermoscopy, pink lesions on a consistent basis, you're actually able to see these different patterns.
And I would just say, as a clinician for many years, I mean, dermoscopy is wonderful. It's helped me a bunch. But sometimes it's really hard. And, you know, a biopsy is, there's no reason not to do a biopsy if you are really scratching your head and staring for a long period of time, which you can do sometimes with dermoscopy, even, you know, the most experienced. I think Dr. Rubinovich and Dr. Buchanan would tell you that sometimes if you're just staring at it that long, maybe it is time to biopsy it.
Thank you for that, Dr. Davis, Dr. Rubinovich. Dr. Buchanan, any final comments or anything to share about John's case, or anything you'd like to wrap us up with?
John did an excellent job. He explained all the features very well, as Dr. Rubinovich said. I like the case because, you know, I think a lot of times when we think about seborrheic keratosis, we think about tan, brown, stuck on plaques, and those can be very easy to tell in the average person. But I've had a lot of patients who, you know, you do 3 biopsies and two out of 3 come back for squamous cell, and 1 is an inflamed seborrheic keratosis. And so, like Dr. Davis was saying, sometimes it's just really, really hard to tell. So, you know, I like the way that John presented certain features that are more common or can be better positive predictors for a seborrheic keratosis. But at the end of the day, you know, you have to make the best decision, and sometimes that decision is to do a biopsy.
Well, thank you for that. And just as a reminder, everyone, again, that part of what we hope to accomplish by providing the equipment for you is making it easy for you to get the expert consultative service, access to the expert consultative services that Dr. Buchanan and her team offer, which could help then facilitate a referral for a biopsy if you feel like it's not something that you're capable of doing in your setting. Again, we're trying to make this as easy as possible for all the providers so that you can make it as accessible as possible for all your patients. I know at this point, I'm going to turn it back over to Dr. Santillano, and we can wrap it up for the day.
Thank you, everyone, for attending today. Thank you, Dr. Buchanan. Thank you, John, for your presentation. And please remember, everyone, to claim your CNE credits and save the date for April 10. So the topic is to be determined, but we hope to have you, everyone, in April. Thank you again for being here. See you.
Thanks, everyone.
Bye-bye. Bye.
Bye. Thank you.
Please, the rest of the TeleDerm team, if you can stay for a few minutes.